Rotator cuff generations in arthroscopic repair. So first generation of arthroscopic rotator cuff is a single row repair. Now single row means you have one anchor and you have 4 threads which are coming out of that, and you use this single anchor to repair the cuff. You use a Mason-Allen configuration here. What that essentially means is you need to pass 3 of the sutures through the tissue and one will be not through the tissue, so it will be from the anchor itself, and you have a configuration like this. So one is a simple suture and one is a mattress suture. So one simple and one mattress makes a Mason-Allen configuration. Now this is a very good technique for a small tear. So either a partial bursal tear or a small tear where the exposed footprint is less than 1 centimeter square. Then in these cases, single row repair is the best. The other condition in which you can do this is a massive tear which is retracted and which is not reducing anatomically completely on the footprint. So in this case, what we do is we will just use it as a lateral row. So we'll just put it on the middle row and we'll repair it in a single row fashion. So we are repairing it in a non-tensioned space. Okay. After that is the second generation. It is a double row. This is an unlinked technique. Okay. So 2 regular anchors, one on the medial side and one on the lateral side. 4 limbs here, all passed through the tissue. 4 limbs here, only 2 passed through the tissue. So this is a mattress configuration for the medial anchor, simple configuration for the lateral anchor. Okay, mattress for the medial, simple for the lateral. This forms a second generation double row which is unlinked. Advantage, both anchors are independent fixation. If one anchor gets loose, the other anchor is not affected. Okay. Third is a linked double row. In this, anchor is put, 4 sutures. 4 sutures are tied and these 2 sutures are then used in a lateral row knotless anchor. Okay. So middle anchor tied and those threads are taken with a lateral row inside. It's a good technique. 2 problems. One, it is a construct. So any one anchor, if it is loose, the construct will become loose. Okay. That is one. The second is it has got more effort of devascularization, because you tie the medial knot and then you put it lateral knot. So this area of the tendon that is on the footprint becomes avascular, and because of that you have a Choi type 2 tears in which you have a musculotendinous level tears. So in the revision scenario it will be very difficult if you have a type 2, because the tendon is here and you have a tear here. This is muscle you cannot repair. So it is difficult to repair Choi type 2 tear. So this is an avascularity issue. The 4th generation is a tape lock technique. In this, you have an anchor here on the middle side. You have one suture and one tape. So one suture and one tape. Okay. And the lateral row you use the tape directly. Okay. So the tape is not tied. This is a non-sliding tape and it is inserted into the lateral row directly, and after that you can close the one single suture on the middle side. So one suture which is sliding, one tape which is non-sliding. You pass all the 4 sutures through the tissue, use the tape as for the lateral row fixation without tying knots, and then the other suture is tied as it is. Okay. So the advantage is the avascularity problem which is there in the 3rd generation becomes less, because you don't tie the knot and then you put the lateral. So this area is still vascular and it is not vascular compromised. Okay. So this is the 4th generation of the rotator cuff repair. So these are the 4th generation. By and large, you can use any generation. They are all having good results depending on the patient profile. But definitely single row for a smaller tear and a very massive tear, and for all else ideally you should use a double row pattern where whatever it is feasible to you. Whatever it is available, that is fine, but you should know exactly the concept how it should be performed. Okay. Thank you.